Welcome to our CMA. We do hope fruitful for all. First of all, let's keep in mind that there is a stereotypical diagnostic pathway for bone SPECT CT, roughly according to 6 steps. First, and you must take into account some epidemiologic facts relating to the medical hypothesis you are raising from your images. Secondly, you must keep also in mind some pathophysiological reminders centered of most frequent bone and joint disorders. You must, from a technical point of view, display CT and SPECT CT layout. Sagittal view is key for spine. 3D VRT adjunct can be very useful, for instance, for the foot. Selection of 4 key features of the lesion of interest, first on metabolic, then on morphological portion of hybrid imaging. The topographic features, type of matrix, margins and limits, and local regional extension. 5, don't forget to be helped by quantitative measure, standardized uptake value for fluoride, uptake, and density, respectively for bone scan and CT of lesion of concern. And then you must derive the differentials. The gamut must be sketched according to similar features on epidemiology, and then you select a pivotal imaging feature in order to bring to your conclusion beforehand. For the spine, I give you some peers according to some clinical condition you know, as I know. 29-year-old Caucasian, low back pain lasting for 1 year, good general health, past medical history, nil, and biological test, nearly nothing. I ask you to scrutinize a whole body scan, which is just here. So first question, multiple choice question. The bone scan exhibits increased uptake in L4, L5, S1, increased uptake of syndesmophytes, increased uptake of ligamentum flavum of L4 S1 segment, increased uptake of common anterior vertebral ligament of L4 S1, or increased uptake of facetal joints of L4 S1 segment. It's now to you to vote. Can you launch the vote, please? No. Okay. So in green are the correct answers, and in red are the erroneous answers. So, as you may think, SPECT CT pelvic-lumbar field of view may be a useful adjunct because of the whole body bone scan findings. Here, the SPECT CT pelvic-lumbar. Here, the lumbar spine sagittal view. As you may see, there is a very peculiar pattern with here a bony expansion, which is anchoring the 3 L4, L5, and S1 bodies like a bony sheet. And you got the matching of MRI T2 fat-SAT sequence with the full involvement of L4. So, according to this finding, what are your main medical hypotheses? Would you label this condition a diffuse idiopathic skeletal hyperostosis, early onset spondyloarthropathy, SAPHO syndrome, tubercular spondylodiscitis, or Bruxellosis spondyloschisis? It's now to you to vote. So that's interesting. Yes, the correct answer is SAPHO syndrome. We are going to examine why. Because don't forget that SAPHO is featured by ossification of core hyperostosis, but also ossification of abarticular structures such as ligament. And for instance, the spinal ligaments have been prone to be ossified in SAPHO syndrome. For instance, in this publication for the posterior longitudinal ligament, but it can occur with the anterior longitudinal ligament, which was the case in this clinical vignette. So let me remember that for osteosclerotic entities condition, you may find miscellaneous condition with very special locations of spinal ligament ossifications. For osteoarthritis, you got interarticular and degenerative enthesitis, which are on the cervical area and in the lumbar area, and it's in asymmetrical disposition. For the dish, you got antero right aspect of at least several bodies of thoracic spine. For Japanese disease, you get an ossification of the anterior common vertebral ligaments of the cervical spine. For spondyloarthropathies, you know very well the bamboo pattern at a very late 10 to 20 years stage of evolution, but at an earlier stage, it begins with inflammation and ossification, which is already very conspicuous on bone scan. Now, to ascertain your diagnosis for this condition, are you looking for cardiovascular signs, neurological signs, pulmonary signs, or cutaneous signs, or digestive signs? It's up to you now, if you can vote now. Of course, it's the seventh step in the diagnostic process when you find on some bone and joint conditions which can be associated to dermatological lesions. You must have a look on the patient and ask the patient. You are not substituting the referring physicians, because only by shaking him hands, you know if he got or she got a palmopustular palmar expression of a SAPHO syndrome, or psoriasis, or lupus pernio-sarcoidosis, or some tache-ole aspect for fibrous dysplasia. So there is no need to perform a clinical physical examination. It's plain, it's obvious, and it bears some prognostic element with this observation. Of course, there was pustulosis, palmoplantar pustulosis in this SAPHO syndrome. So the answer was spondylitis L4-S1 with ossification of CAVL. So you must be very cautious about some variant, minimal variant, about thoracic anterior parietal localization. You must also be cautious about the posterior thoracic locations here, but always the same pattern with very regional extensive pattern by patches all over the skeleton on a protracted course. So SAPHO syndrome, as I was just telling you, is another one SCIBO disease. SCIBO is the acronym for skin plus bone manifestations. It's one of the conditions when you must search out very easily dermatological cues to foster, to strengthen, or to discard your first diagnosis grounded on skeletal manifestation. So it's synovitis, acne, pustulosis, hyperostosis, and osteitis. As you can see in SAPHO syndrome, roughly half